The application of the sliding fee discount in pharmacy services has been vague for some time during operational site visits. This has created a lot of confusion for community health centers. On today's episode of 340 Banter, Chelsea and I are going to discuss some recent updates to the site visit protocol which clear up a lot of the confusion.
BPHC, or the Bureau of Primary Healthcare, has recently released an updated site visit protocol, or SVP. We have so many acronyms today, or SVP, for their operational site visits, or OSVs. Can you talk to us a little bit about what is an OSV? How often do they happen? Who has to deal with them?
Yeah, and I think a lot of people in the 340B side of health centers don't know a lot about OSVs. But every health center and every health center lookalike has to have an operational site visit once a year, previously was once every 3 years. They're moving to a 4-year cycle. So it's once every grant period, basically. And the idea of this site visit is that they come in and they ensure that you're following health center compliance rules.
So this is outside of the 340B program. It's just
exactly.
the health center, and health centers get their funding through a 330 grant. So it's kind of tied to
it's making
grant.
Sure they're in compliance with their grant. And the reason pharmacy staff and 340B staff don't typically know much about it is there's very few areas that really overlap. But there are a few places that we've seen issues in the past during OSVs when we've had health centers calling us saying, I don't know what to answer. I don't know what they're looking for.
Yeah. So one of those areas that has caused some questions or concerns across health centers and honestly across the OSV reviewers as well has been around the sliding fee scales. So as part of a health center's operations, they have to be able to offer a scale to slide fees down to a lower cost for individuals that are at lower income levels, so that they can get their care despite their ability to pay. And there are some very specific criteria on where those sliding fee scales need to be applied. And historically, the language has been a little bit ambiguous or left some gray area or questions around the pharmacy administrative fees. So supplies don't need to have that sliding fee applied to them. So drugs, prescriptions that we dispense are supplies. We don't have to apply that discount or that slide to those. However, there has always been this question of the fee that goes with it, which is really the overhead for retail pharmacy.
The cost of doing the business.
Yes. So the question, does that sliding fee need to be applied to that? How does a pharmacy operationalize that? And it has caused a lot of confusion over past years. And this newest update really clarifies the intent behind it, which will help a lot of health centers in updating their policies and kind of solidifying their operations, but also provide clarity for the reviewers, where historically we've had some challenges where, reviewers and health centers have different interpretations of what that has. So can you talk to us a little bit about the changes that have been made to clarify that sliding fee scale application?
Yeah, and I think the key thing is a service versus a supply, because services do require that sliding fee scale because they are required under the health center grant. So the updated language really splits the language into 2 bullet points. And the first one is talking about clinical pharmacy services. These are the services like medication therapy management, or other pharmacy encounters where a clinical pharmacist, I don't love that term.
No, nobody does, but we don't really have an alternative in the space at this time.
But a pharmacist sits down with a patient, they go through their meds, they provide recommendations, they may be prescribed depending on the state and the laws. But it's more a traditional, you think of it like a medical provider having that service. Yeah. That is considered a service and does have to comply with the sliding fee rules. However, they put a new bullet point in that clarifies that a pharmacy dispensing fee is considered an overhead cost.
Because
And
it is.
yes,
As you said, it's the cost of doing business. It's the cost of the staff, the building, the vial that the pills go into.
in fact, exactly. And you can think of it like Medicaid. So Medicaid has to do a survey. Every state has to do a survey regularly of the cost to dispense a drug. And that cost is what makes the professional dispensing fee. So it's really the goal is a break even if you're getting for Medicaid, if you're getting the acquisition cost plus the professional dispensing fee.
You're not getting any revenue
Yeah.
on that.
There's no margin there.
Yeah.
So once BPIC was able to understand that that's an overhead cost, they made an update that said it is not a service and that professional dispensing fee doesn't have to comply with the sliding fee scale. However, you are allowed to discount it or not charge a dispensing fee if you want.
They're never going to tell you you can't provide that additional discount to patients, make care easier to access, but they're not requiring it for that overhead cost.
Yes.
It.
And especially in our contract pharmacy space where some contract pharmacies can't do a sliding fee, especially graduated.
Yeah.
Because the sliding fee requires at least 4 levels.
For the way that it's framed in the BPIC
If it's
requirements.
a service.
Yes, not necessarily the contract pharmacy.
Yeah. So because that wasn't possible, this gives us a lot more freedom. We can still provide a discount, but maybe we provide one level of discount for the eligible patients. And operationally, that's a lot more feasible for pharmacies, both entity-owned and contract pharmacy, to do than to provide the regimented requirements under the sliding fee scale.
So now that we know that the administrative or dispensing fee for the pharmacy is not required to comply with the sliding fee scales, but organizations are still able to provide those discounts. Let's talk about how those are operationalized across different health centers and different venues. So your entity-owned retail pharmacies may look very different from contract pharmacies, and one contract pharmacy to another may be different in how you're able to apply that discount.
So one of the first things I do if you have mentioned pharmacy, dispensing pharmacy in your sliding fee policy and procedure, be aware if it's mentioned there, HRSA is going to expect you to comply with the rules there. So you may want to remove it from there and put like a freestanding pharmacy pricing policy and procedure. That way you're not getting a reviewer to look at sliding fee if you're not meeting those requirements. But I think what we've seen a whole variety of the way people do this in the health center space. But I think most people now are doing a cost plus a dispensing fee model. That way, they don't have to create a specific formulary necessarily. If a drug is affordable, its 340B price is affordable, then that will make it affordable just by charging that small dispensing fee. And that seems to be the most common, but we've seen everything from even flat rates. And I've got a client who doesn't charge anything for their patients who are less than 100% of the federal poverty level. And I think that's a great service to provide your patients.
Yeah.
I shouldn't use the word service. That's a great benefit to your patients to provide those drugs free of charge. But that is not an expectation of HRSA that you will take a loss on the cost of the drug. So that does require a little bit more management because you got to make sure that your formulary is tight. You obviously can't provide a drug at no charge if it's going to cost you thousands of dollars.
Yeah, I've also seen health centers that have used a sliding fee, a graduated sliding fee in their pharmacy that are a percent based on a percentage of AWP or something like that.
Yeah.
And oftentimes they align the patient eligibility for that program just right along with the sliding fee scale eligibility for the health center. So based on
I think that's wise.
Yes. The designation or the evaluation and designation that's done by, the care manager, care coordinator, whoever is doing the evaluation to qualify for the patient for sliding fee for the health center as a whole and their medical services, also kind of passes that information on to the pharmacy. And then the way that that's done in the medical side does have typically an annual timeline to it. So there's not, a patient isn't allocated to the sliding fee scale forever. It needs to be revisited at an interval, often annually, but can be shorter or longer, I think, depending on the health center. And so really important for your pharmacy staff to then know where to go to verify that information, if it's living in a different place, if it's in the medical record, as well as looking at your pharmacy software to see if there's a way to put in a note or a flag or something for when that patient's sliding fee scale status is due to term or up for review.
I think with that, most pharmacy software, and this goes whether you're using a graduated scale or if you just have a discount program, if you want to put an expiration date, often you can put an expiration date on that plan in your pharmacy software. That will remind your staff to either do the redetermination or look for it in the EMR. My health center is one of those that has a graduated scale, and our redetermination is a little unique. We don't do a year from the time it's evaluated. It's every March 1st. So it's a set date.
That's a hefty lift for March. Holy cow.
Yes, it would not have been my choice, but they every March 1st, our front desk know that they've got to redetermine sliding fee scale. So our pharmacy staff know what team on the front desk team to really get with to redetermine if the patient hasn't had that done. And I like having that firewall between the pharmacy making that redetermination for just for integrity of pricing.
Yeah.
So I think it's good to have another team doing that, and especially if it's a care coordination team, because they're so skilled at working with those patients.
So if we switch gears and talk about contract pharmacies, how do health centers, but also, hospitals provide discount programs through contract pharmacies as well? What does that look like typically?
So I think with contract pharmacies, it's really dependent on the TPA and the pharmacy. But we often see these cash cards, and some of the chains can't provide them. So that's one of the biggest barriers is chain participation. But it's really what I've seen the most is that there's a fee charged by the TPA to provide the cash discount. And then you set up your dispensing fee that you pay to your pharmacy, and then the cost of the drugs just added onto that. So the health center or the covered entity is not making any money on the claim. They're doing it as a benefit to their patients and a way to access care. But the first step's really talking to your TPA and seeing what's available, because you're going to be limited on what their capabilities are.
Yeah.
Then we'll move on to the next step of talking to the contract pharmacy and see if it's possible. But generally, those are set up through a pharmacy benefit manager. Your TPA will provide that. And all the pharmacy will do is bill this whatever discount plan through your instructions. We'll bill it. A lot of times the ID is the medical record number and things like that. And they bill this, and it gives them the price real time so they can charge the patient.
Yeah, I think that one of the important things to remember when implementing those, in addition to having to go through the process of just identifying if the TPA can support it, if the pharmacy can support it, and if you can have a graded scale or just, a single discount program, is looking at the qualification criteria for your TPA for that contract pharmacy, and if they utilize different logic for their cash card program. So we've seen challenges with maintaining the list of eligible patients for the discount program. We've seen challenges where the provider list, the provider NPI list, does not necessarily automatically apply or carry over to that cash card program. We've seen instances where right now the manufacturer restrictions, continue to be impactful and challenging.
That's a huge barrier to cash cards.
And and a lot of those NDC blocks at the TPA level have not, in many instances, been carried over to those cash card programs. So things have been allowed to go through. The patient is charged whatever the 340B cost would be or should be, but the covered entity is unable to replenish that drug at a 340B cost and ultimately ends up having to replenish it at WAC
Yep.
or having to true up at WAC, which is incredibly costly to the covered entity, depending on what that scale is. So really important to understand and put in controls at the beginning of this process so that you're not identifying that later on and owing a lot of money to the pharmacy and the TPA, where really your goal was not to make money, was just to be able to extend this discounted pricing to the patients and the community, and you kind of you're able to provide that without generating or incurring any costs for your organization. So important to hone in on those details at the beginning.
Yeah, and I think if you're working through a chain, we've seen challenges when the chain has a gateway processor. So it's not just your TPA. You also need to make sure your TPA is in communication with that gateway processor to make sure that those factors aren't going to happen down the road, and we're going to find out in 6 months that we have a large true up.
Yeah.
Thank you for listening to 340 Banter. This podcast is produced by Grit and Gravel, your partners in marketing strategy and success.